What is up, everyone? Apologies for the delay. As you know, if you've been watching this long enough, is that we always have technical difficulties. It's always planned though. That was not an accident. How you doing, Adam?
I'm great. How you doing, Haney?
Very, very good, very good. And I'm very excited for today's show because we have special guests and a very special topic. What are we talking about?
So we are going to talk about RV dysfunction, specifically in ARDS.
Hmm, interesting. Sounds like we better have some experts on if we're going to talk about that. It can't be you and me.
That's right. So let me introduce them, and then we'll bring them on. So two guests I'm very, very, very excited to speak to. One is on the left there. We got Dr. Jason Bartok. He Cooper intensivist and the program director for our critical care fellowship. Jason, how you doing?
I'm doing great. How are you, Adam? How
Good.
are you, Haney?
Awesome. Thanks for being on.
And then in the middle here,
Appreciate
we
the
have
invite.
Dr. Oh, of course, we have Dr. Hollenberg, who was at Cooper, and I think he left because he heard I was coming there, and so he took off, went to Jersey for a while, and now is in Atlanta, right? Where he's the head of the
Correct.
cardiac ICU.
Emory.
Emory. I'm sorry. Yep, that's right.
Yeah.
Head of the cardiac ICU, and you're unique in that you have training both in cardiology and critical care medicine. Is that correct?
Yes. Not entirely unique, but it's somewhat uncommon.
Uncommon. Very good. So with that said, Haney, should we start?
Absolutely. Let's go.
All right. I'm up first. So we're just trying to punch it since we started a little late. I am ready to be schooled. And so I'm hoping this hour highlights all of my inefficiencies as an intensivist. So, when I think about RV failure and ARDS, something we always talk about, and I think we have probably a variety of learners here. There's going to be what I'm going to say the total novice like myself, and the black belts like you two. And so, just give me a little bit about acute versus chronic RV failure. How are they different? Are they the same? What's your mentality? I mean, I guess I'm pulmonary trained, so I'm kind of thinking someone with chronic COPD who has learned to live with their poor gas exchange is very different than someone in acute bronchospasm. Is that kind of the same for RV failure?
So
Jason
the
or
short
anyone?
answer,
Yeah.
the short answer to that is yes, and for sort of the same reason. So chronic right ventricular failure is going to be adaptive. You're going to generate pulmonary hypertension, but the right ventricle is going to have time to adapt to that, and in general, that's going to be associated with right ventricular hypertrophy. And actually, the rule of thumb on an echocardiogram, if you get a good measurement of free wall thickness, is that 1 millimeter of 3 mol thickness equals 10 millimeters of systolic pressure chronically. So that's adaptive, and the right ventricle has time. Acute right ventricular failure happens generally when the afterload goes up, and those patients may not be able to generate pressure because the RV failed. So to some extent, a good right ventricular systolic pressure suggests that the ventricle is able to generate pressure, and the patients who are really in trouble are the ones with pulmonary hypertension who can't generate that pressure, and their systolics are in the 30s and 40s. They're in real trouble because they have acute RV failure. And those are also the ventricles that blow up and don't pump, as opposed to the ones that are adaptive and they may be big, but they pump reasonably well.
Yeah, no, I mean, I think that's a great explanation. And for me, being a sort of a simple intensivist and not a cardiologist, but trained by Dr. Hollenberg when I was a trainee at Cooper, um, learned a lot about RV dysfunction and RV failure. And for me, I sort of set having to be simple, and I separate everything into buckets. So certainly, a dysfunctional RV, but compensated. So dysfunctional in the way that it looks, but compensated in the fact that you probably don't have a tremendous amount of symptomatology versus failure, I think are a little bit different, both in the acute phase and the chronic phase. And the way that you present both on echocardiogram, just like Dr. Hollenberg said, and then symptomatically in the ICU, I think are very different between acute and chronic RV dysfunction versus RV failure.
I
So
got
let
it.
me ask you Let me ask you both a question with that, because it's obviously whenever we have something in critical care, you always want to fix the underlying cause. So we always say that. But in terms of when you find out someone has acute versus chronic pulmonary hypertension, are there any differences in the approach to managing the pulmonary hypertension between those two populations of people?
So, I mean, I think for myself, it's the sort of the triad in your approach, optimizing preload, optimizing afterload, and then maintaining, contractility or optimizing contractility. I think the approach, depending on how sick your patient is the same for me. I think you try to figure out what the primary driver is in somebody, whether they have, whether they have chronic, compensated, you know, pulmonary hypertension and RV dysfunction, chronic exacerbation. You have to figure out what the primary. I'm not driving in a car, so it wasn't me. Did you guys? Yeah. What I think what the primary driver is, so you have an opportunity to fix the underlying cause. I think that depending on, for a lot of these patients, whether it's, for most of these are going to be group 2, maybe group 3 pulmonary hypertension. There's not a lot of, action that you can take that's meaningful for reducing those mean pulmonary pressures, I think, other than, trying to optimize afterload with primary drivers and what that preload is, hoping that contractility stays the same. But that's pretty much my approach.
So I think the distinction you made between right ventricular dysfunction and right ventricular failure is really key here. So chronic right ventricular dysfunction, those people whose right ventricles may not pump very well and they may have pulmonary hypertension, but they're dyspneic on exertion. Those people in the ICU you're going to leave alone. They don't necessarily have an acute problem. It's the people with acute RV failure that you need to deal with, and so that's when you address the underlying causes. And I agree with that. In general, the preload is high, the afterload is high, and you want to deal with that. And the contractility is high. It's not really. The RV doesn't really have preload problems. It's designed to be compliant and to handle variants of preload. So it's mostly afterload and contractility that you're trying to manipulate, as well as, I know we're going to get there, what you really can address is what's going on in the lung and what is driving the acute heart failure, in the acute right heart failure in ARDS.
That's great. So let me ask a question then. And remember, I'm the novice who doesn't know how to turn on the mind ray. Okay, how do I? I'm the intern. It's middle of the night. I walk up to the patient. What tells me, shit, the RV's doing poorly? What should jump out? And we can say an ARDS patient, or we can say any patient. Is it just peripheral edema? Is it JVD? Like what are the signs and symptoms that scream that we're in trouble?
So in general, in an ICU, that's really hard to do because, as you know, the world is a complicated place. And with the exception of acute PE in somebody who is otherwise fine, who has acute right failure, what you're dealing with in the complicated situations is acute on chronic right ventricular dysfunction. And so those people are going to have JVD and they're going to have edema, and you really aren't going to know what the ventricle is doing acutely, except if you do an acute measurement. And there are two ways to do it. The first is to take out some sort of echocardiographic imaging probe and take a look at it, try to figure out what's going on. And the second is to take out that ancient but yet useful technique and measure the pressures in the right-sided circulation and try to get a sense of what's going on.
And that is the beauty of working in the ICU and training under Dr. Hollenberg. We got to do both, and it's something that we continue to preach to all of our trainees. I mean, I think when it comes to static measurements, it's always great to kind of be able to trend over time, but trying to get an idea of how the RV is functioning. I don't know if Dr. Hollenberg has any input. I mean, most of our fellows are pretty facile with point of care ultrasound. Feel pretty confident in getting a baseline understanding of what they think the RV pressures are, plus or minus whether or not the patient is positively pressure ventilated. then trying to figure out, what the function looks like on TAPSE. Maybe they get an S prime. Maybe that's too much. I mean, the chamber sizes are usually pretty bad to begin with. They'll, try to, if able, can calculate PA systolic pressure, using modified Bernoulli's. I know that probably just sounds like a lot, but I mean, those are sort of, as you're marching your way up, trying to confirm what your clinical gestalt is. I think, those things have all been really, really helpful. Yes, static, but it's great to trend those over time so you have more of a dynamic range. But the PA catheter, I think, is really important. And one of the things, especially as we start to dabble more and more in mechanical assist, I'm be interested to see what Dr. Hollenberg's thought are about, what the best pressure measurement enters, or like something like a sense of impending. And we talk a lot about, PAPI and things like that, that will trend over time to see whether or not, that RV is continuing to spiral out of control or at risk to fully fail.
So I agree with all of that. A couple of things to say. Even that imaging that you're talking about is what I would say is level 2 echocardiographic imaging. You're using Doppler to measure the tricuspid envelope to get a sense of the trans-tricuspid gradient. TAPSE, tricuspid annular systolic excursion, is also a little bit beyond just the first level. So and so in imaging, I guess the real lesson here is imaging the RV is hard. It's really, if there are indications to try to get a tech to come in the middle of the night, a good evaluation of RV function is one of them. It's not so easy to do, and it's not something that your intern in the middle of July who knows how to turn on the machine is going to be able to get you a particularly good picture. You're going to need to go one level up. So it is, handle with care. And what you see a lot, for example, the best ways to measure RV size is in the apical 4-chamber view. And the classic parasternal view is not a good way to look at the right ventricle because it's very dependent on the angle that you cut it at. So you see a lot of people put the probe on the chest, get that parasternal view, take a look at what they say is, oh yeah, that RV is big. And the answer is, well, the RV may be big, but it may not be big. It depends on how you cut it. You need multiple views and this and that. It's just harder than it originally seems. It takes a little bit of seasoning to do it right, which is not to say that a well-trained intensivist it can't do it right, and that not to say that every cardiologist can do it right, because even the cardiologists can't do it half the time. But it is something that takes some care. PA catheters, really the sine qua non is PA catheters, and as you know, that many of the clinical signs. So the jugular venous pressures are a little difficult to tell in an intubated patient, and the peripheral edema is always present. And as you probably know, the IVC diameter is not reliable measure of filling in an intubated patient, which is usually what you're looking at. So actually, and in the pulmonary hypertension world, there's a fair amount of data. Let me go back one. The estimate of right ventricular systolic pressure equals the trans-tricuspid gradient plus your estimate of right atrial pressure. So the trans-tricuspid gradient is usually accurate, and that usually, with echocardiogram, matches very well with what you'd measure with a PA catheter. What doesn't correlate at all is the right atrial pressure estimated by echo. And so if you estimate 5 and it's really 20, or you estimate 20 and it's really 5 from an echo, you'll make an error of 15 millimeters of mercury. So that's where the error comes in estimation of right ventricular systolic pressure by echocardiography. And so for type 1 pulmonary hypertension, when the pressures are sky high, all the pulmonary hypertension people will tell you that the most reliable numbers are obtainable only by invasive measurement. And that's not to say that you can't trend them, because the right atrial pressure probably isn't going to change, but it is to say that the gold standard for this disease really is hemodynamic measurement. And you mentioned the PAPI. That's the Pulmonary Artery Pulsatility Index. And that is basically the pulmonary artery pulse pressure, systolic minus diastolic, over the right atrial pressure. So it's a simple ratio. And you want to have a high pulse pressure, indicating a high stroke volume, and a low right atrial pressure. You want that number to be high. When your pulse pressure is low and your filling pressure is high, that's a low number, and that's trouble. So when a PAPI gets below 1, you're in trouble. With mechanical support, the threshold's a little different. But when that PAPI begins to stay low, particularly in the setting of cardiogenic shock, that's when the trouble happens. So it is evaluating pulmonary hypertension is one of the more useful uses of right heart catheterization. Still, even in 2022, it's getting increasing recognition of its utility.
I agree. And a very important skill set for all intensivists.
Yeah. And so let me stay with that, because we know it's an important skill set. We have to be realistic as well. The expectation that every intensivist is going to go down that rabbit hole and know how to adequately assess the RV, at least early on, would be unreasonable to expect that everyone would. So my question to you is, when should someone pull the trigger and say, I would like to call someone in? If it's 3 o'clock in the morning, you have someone who's really sick, what things should the novice to intermediate person look for before they say, like, I think something is at play here, now I need someone else to come in here and confirm, because this is going to change the trajectory for my patient?
So I guess I think the operative word in that statement is trajectory. So basically, to me, the calculus is the patient doing, let's say, so for this purpose, let's call therapy without right heart catheterization empiric therapy. Mm-hmm. Now, maybe it's based on echocardiography or whatever, but it's empiric therapy. Without a PA catheter, you're going to take some therapeutic option and you're going to go and do it. So if that's working, that's no problem. But when your empiric therapy isn't working, you're doing what you can with the tools available and it's not working, now it's time to me to say, I need more information. And this principle isn't really specific to right heart failure or anything else. If what you're doing isn't working, try to think of doing something else. But in this setting, that something else is, maybe I need more reliable invasive measurements of right ventricular pressure so that I can figure out how to change what I'm doing, because what I'm doing based on my knowledge now isn't working. I have failure, I have perfusion failure, I have my mixed venous saturation is low, my hypertension is persistent, et cetera, et cetera. My urine output is gone away.
Yeah, and I think that's what we preach to our trainees, and sort of what our seasoned intensivists advocate for in our ICU. It's that patient is in shock, patient is failing, patient has progressive organ dysfunction. So if you have if your clinical pretest probability is for right heart dysfunction, we said there's a triad of things that you need to try to best optimize. Probably one of them being most impactful in that moment. I think that's the time to pull the trigger for help if needed.
And in the real world, that may not be at 3 o'clock in the morning, but the sun is coming up. And when the sun comes up and you've been wrestling with this all night, now it's time to call somebody who doesn't have to get out of bed to do this, and but is already coming in the hospital and say, something, I've been failing all night and I need some help.
And I think it's, for those of us who aren't cardiologists, it's finding yourself in that situation early in your career that causes you to reach out and add a lot of these assessment tools to your repertoire, right? Trying to become a little bit more facile in image acquisition in a safe way. Making sure that not only can you load a PA catheter, but you can set up a swan box if called upon to do so. Things like that, I think, can really help a patient who is set up to fail.
Yeah. And Jason has certainly heard me say this in other contexts. So I think it makes no sense to say that you're always going to use a PA catheter. I also think it makes no sense to say that you're never going to use a PA catheter. So that leaves you with you're sometimes going to use a PA catheter, which implies two things. First of all, you got to figure out when that is, and that may differ for different people. But secondly, it helps to know how to do that. And you probably don't want to do your 1 PA catheter a year in the sickest patient you've ever seen. You kind of like to, and the docs don't know how to hook these things up, the nurses do. So that means that you have to see some value in being able to do it. If that means taking everybody to the cardiac catheterization laboratory to do it, so be it. That may be true in some places. But I don't think it really makes sense to say, because I never use a PA catheter, I'm not going to train my people to use a PA catheter because they're never going to use it, never going to need it. You sure about that? So if it's possible that they need it, then show them how to do it, teach them how to do it, and let them make their own decision about whether they think it's useful or not. So
Well
Bartok.
said.
Agreed.
Well said. Yeah, no argument here. I'm a fan. I think along the same lines, every intensivist encounters a patient every year that desperately needs a PA catheter, and for that to be the only time you do it is just asking for trouble.
Yeah.
So I'm pro PA catheter. Let's shift with time in mind. Let's shift to the topic, which is ARDS. So talk to me about the pathophysiology. Why does the right heart fail in ARDS?
So this is afterload, and to me there are 4 factors. So the right, as you all know, the right ventricle, the left ventricle tolerates afterload, the right ventricle does not. The right ventricle fails when faced with afterload, and so there are 4 things that can raise right ventricular afterload. So hypoxia causes pulmonary vasoconstriction and raises afterload. Turns out substantial hypercarbia raises right ventricular afterload. So you want to manage to ventilate, avoid hypoxia and hypercarbia. That sounds like a platitude because it is. And now atelectasis is bad because it collapses alveoli, and that decreases the number of pulmonary vessels. And so enough PEEP to deal with atelectasis is good. However, too much PEEP over distension is also bad, because you'll remember the West zones. You have West Zone 1, 2, and 3. And in West Zone 3, the alveolar pressure is higher than both the pulmonary arterial and venous pressure, and it closes those and it decreases the number. So you've got those 4 things. You got hypoxia, you got hypercarbia, you have over distension, and you have atelectasis. And you kind of have to get those all together. So doing that all together is not so easy, right? Your PEEP improves your hypoxia and hypercarbia, but then there's the potential for overdistension. So that's really, it really is involved 2 phases: addressing the underlying ARDS, and then sequential imaging to see how your right ventricle is faring with what you're doing. How do you get the PEEP that's best for the right ventricle? You play around with it, you see what the right ventricle does. And that really is serial imaging. Your PA catheter doesn't really help you quite so much with that.
Yeah, I don't have anything else to add. No, but I mean, I think that was a really elegant, and systematic way of breaking down, why ARDS causes high pulmonary afterload and failure. And I think a lot of it has to do, yes, with the underlying pathophysiology, doing all of those things, and some of it has to do with how we control the ventilator and whether we do it safely. Just like you said, I mean, alveolar hyperinflation and alveolar collapse are probably 2 of the things, that we could do better, which, is why we advocate for, optimal PEEP and probably prone positioning. All those things can improve compliance and probably impact your RV afterload, ensuring that the patient has, again, everything's about compliance being a measure of transpulmonary pressures. You don't want that underinflation for alveolar collapses. I think, very important when it comes to small vessel increases in pulmonary vascular resistance. Ensuring that you have adequate lung inflation is also important because, for the large vessels, there's radial forces that, when the lungs inflate, they increase capacitance in the main PA and can also maybe offload some of those elevations in PA pressure. But, if you're, under recruited and collapsed and, and underinflated, that's a really dangerous place to be. And the other thing is there's probably some impact on, for mechanical ventilation that I don't think a lot of us talk about, the non-mechanical sort of humoral response, molecules out to get you. When you have high transpulmonary pressures, probably there's some impact on the right atrium that may dampen, your natriuretic peptide release and can lead to, increase in volume retention, which is why I think, and even in the non-ARDS population, when you look at, all comers, probably another thing that impacts why patients tend to be volume overloaded when they are on mechanical ventilation. It's not just all of us, exponentially bolusing our patients into death. It's probably some of it is there's some humoral response with the way that positive pressure impacts the right atrium, but I don't know, maybe not. But I think that that all of those things together just sort of prove that you have to have a systematic approach and thinking. When you're treating a patient's ARDS and you're focused on the lungs, you have to think about what sits between those lungs, and those heart-lung interactions really make up the bulk of what critical care is and what drives outcomes early. Whether your primary problem is cardiac or your primary problem is pulmonary, if you mismanage one, you will have problems in the other. So,
yeah. And we probably should talk about volume too. So the classic teaching in RV failure is give volume. And you have to recognize that teaching comes from right ventricular infarction in the setting of inferior wall MI. And even those papers, so those suggest that if you're dry, if you give nitroglycerin, your pressure goes away, you need to give some volume to the right ventricle to increase cardiac output. But even those papers suggested that above a certain level, it plateaued. And as you give too much fluid, you push the septum into the left ventricle, and then you decrease left ventricular filling, and then your cardiac output goes down. And so in ARDS, you're almost never dry. And as a matter of fact, you're wet and the right ventricle is over-distended. So kind of two lessons. The way to follow how you're doing with your PEEP is serial echo imaging and look at the position of the septum. You want it to get out of the left ventricle and move back toward the right. And in general, the way to treat right ventricular failure in the setting of ARDS is to dry them out as much as you can. They're always wet. Their right atrial pressure is always high. This is not RV infarction where you give fluids. This is where you try to get rid of fluids.
Yeah, no, I think that's a really good point. That concept of, I guess, ventricular interdependence, where your right heart bows the septum in the left heart, and the left heart output goes down, and that's where that downward spiral really takes on. And finding optimum PEEP, I think, is very important, because I think some of us grew up recruiting patients, right, in ARDS to try to improve compliance by popping alveoli open. I mean, it makes sense, and we all did it, and we all continue to do it when we face those situations where we can't oxygenate. But I think that a lot of us were taught that the hemodynamic swings that you see in recruitment maneuvers, 30 centimeters of water for 30 seconds or 40 for 40 seconds, a lot of those come with a reduction in preload. And I think some of that might be true. But when you look at it under direct, echocardiography, you can see that, that those high intrathoracic pressures, for all the reasons that we talked about, can cause a spike in RV afterload, and then can cause that septum to shift into from the RV into the LV, and then impede output. So some of those swings in hemodynamics come from a sudden increase in RV afterload from the recruitment maneuver, and not just at least when I was trained, it was always, they get hypotensive from a reduction in preload, when, in reality, and if you subscribe and, read a lot of what Martin Tobin writes, it probably has a lot to do with an increase in RV afterload, and that septum, sort of, impinging upon, LV output. And those recruitment maneuvers can be very dangerous and will be very detrimental in your patient who has, RV dysfunction or progressive RV failure in ARDS. And that's the patient that during a recruitment maneuver could easily code on you. So, whether or not you choose to recruit, you should consider doing it, maybe at lower pressure for a shorter period of time. And then maybe if you feel comfortable or facile, can, take a look at it under echo. And if you start to see that, that shift in the septum, it's probably not a good idea for that patient.
Yep. So let me ask you this. When you have a patient that you are evaluating, let's create this scenario where you get a patient who's transferred over to you, and you go to do your initial evaluation of the RV, and you see that it's distended, you see it's dysfunctional. Is there anything there that would tell you prognostically just how well this patient's going to do long term? Does it tell you that this person, they're not getting back to normal RV function? They're always going to be left with a significant amount of dysfunction? Or is there that window to optimize preload, decrease afterload, ionotropy, all that stuff to get them to where they once were?
I mean, I don't get the opportunity to take care of a lot of patients in the outpatient setting, so I can get everybody out of the ICU one way or another. But yeah, I mean, I think at least from an ARDS standpoint, at least a quarter of our patients will end up with RV dysfunction during their ARDS course. Probably more. When you look at some of the data that came out in COVID, probably more than that. And maybe that's just because we looked more during COVID, or maybe they had longer runs of mechanical ventilation. It seems like that as you treat the ARDS, provided that these patients didn't have other underlying comorbidities that put them at higher risk in terms of chronic pulmonary hypertension. It seems like it's reversible, and at least that's anecdotally in my practice. There's a lot of reversibility and return to normal function. I'd love to know what Dr. Hollenberg thinks.
Yeah, I feel the same way. I mean, from broad sense, obviously, the patients with RV dysfunction would be expected not to do as well as the patients without it. But to me, the most important prognostic factor is failure to respond to therapeutic maneuvers. If you don't do that, you're in big trouble. But if you do, you can look, let's just take an example. You can have a right ventricle looks awful in the setting of pulmonary emboli. If you get that patient through and the pulmonary emboli go away, the RV comes back to normal. So I think it's really more the response to therapy that's prognostic, and it's not long. If you're not responding to therapy, you're not exactly worrying about long-term prognosis. It's short-term prognosis is keeping you awake.
Right.
That's great. So let's talk about therapy. So I understand. Set the vent correctly, dry them out.
Yep.
When do we use Flowland or Velletri or nitric or whatever you want to call it? All of them? None of them? What are the side effects? Who are we worried about?
Yeah.
When you're desperate. I would say you are. So I'll give you my take. If you're considering those agents, you are concerned enough about right ventricular function to be measuring it invasively, because you really want to see the pulmonary pressure response to your intervention. And you're going to and echocardiography and invasive monitoring go together, but nothing is working, and you're going to try a pulmonary vasodilator, and you're going to look at a number of responses. You're going to look at the response of the pulmonary pressure, because that's what you're titrating to. You're going to look at the response of your arterial blood gases, because that's your ultimate problem. And in general, if you're thinking about this, you're not oxygenating. You may or may not be releasing CO2. And you're going to look at the position of the septum. So I think that's a measure of desperation. We're talking about this for pulmonary hypertension. I'm going to leave aside the notion about whether those agents improve ventilation perfusion mismatching and are useful in ARDS. Phil Dellinger's trial would say no, but
Yeah, no, and I think that's a good point. Phil Dellinger did a lot of work early in the use of pulmonary vasodilators, and I think their impact in at least acute right heart failure are limited. I mean, you'll just like in ventilation perfusion mismatch and utilization in ARDS patients, I think you see maybe an early drop in those PA pressures, and it may buy you some time as you oxygenate better. Maybe it's from the oxygenation, maybe it is actually a reduction in afterload. I mean, these aren't group 1 pulmonary hypertension patients, but just like in the VQ mismatch trials, you tend to see them lose that benefit after 72 hours, or more. And it's just hard because once you put it on, you never take it off, right? And then there's so many other things as you sort of bleed, inhaled epoprostenol into the patient at all times. You can't give them bronchodilators if they have underlying obstructive lung disease. So there's a lot of things that can compound on top of that. So for rescue hypoxia, sure. I think for, if there's, when it comes to acute afterload reduction, variable.
So I also
we all do it though.
Yeah. Well, we should clarify what the ARDS trial. Dr. Dellinger did a trial of inhaled nitric oxide at 4 different doses in patient with ARDS. What that trial showed was that gas exchange was improved, but the outcome wasn't gas exchange. The outcome was resolution of organ failure and mortality, and neither of those was different. So exactly what you said. It'll make your blood gases look a little better. It was hard in that trial to demonstrate, but that trial actually didn't really look at pulmonary pressures. That wasn't one of the outcomes. And so to me, inhaled vasodilators for oxygenation and gas exchange is conceptually different from using them for pulmonary hypertension. You would follow pulmonary hypertension and see whether that makes your patient better, whether it makes your hemodynamics better. But that's not studied at all, actually. And
But
in the
don't you
same
want to
way,
feel?
yeah.
I said, don't you? But don't you just want to feel good, like that moment on rounds when that patient just something that's showing you the patient's doing better?
Well, so it makes the physician feel better. What's less
That's
certain
all
is
that
whether it makes
matters.
the patient do better. Yeah, I know.
Yeah, it's interesting though, Haney, because like patients with ARDS don't usually die from hypoxemia, right? We're getting
Right.
off on a little tangent. They die from multi-organ failure, from whatever was
Hmm.
driving the
Right.
ARDS. So
Right.
I don't know. I'm an anti-pulmonary vasodilator just for hypoxemia for sure.
Me too.
All right. So let me ask you this, and we're coming to the end, but there's definitely one question that I want to ask you. Getting people on board for diuresis. So you agree that the RV is dysfunctional. It would do much better by having a reduction in volume, get back on that Starling curve. Two-part question here. The first is, with your big brains, how do you convince people that what you're doing is the right thing? Because you'd always like people to come along with you, and what's the best way that you explain it? And then the second question is, how aggressive are you on day 1, 2, 3? How do you gauge how aggressive to be with that diuresis? I like to poll people on this because I see a variety of answers for what their goals are. Admittedly, some of these goals are just made up, but it's still interesting to see. I'd be interested to see what you both do in your practice.
So, I mean, you need targets. My whole life is, set around targets. I'm not that smart. I just need a target, and then I can go after it, and then hopefully things get better. I mean, I think, when you have pressure targets, and then you have organ system targets, and I think a lot of times, if you don't have access to a PA catheter, you have organ system targets. Maybe you have a little bit of static measurement. So I think, in the setting of a patient with progressive renal dysfunction, likely due to congestive, failure from the right heart, I do use point of care ultrasound to make a diagnosis, and then, diurese for return of organ function. So, I think so, and we can all argue, how much data is out there for portal venous pulsatility index and things like that, especially in somebody who has RV dysfunction and probably their tricuspid annulus doesn't work well and they got a lot of TR and blah, blah, blah. But at least, you think that it's congestive, and you can sort of see that on ultrasound and target, probably put them on an aggressive Lasix infusion. But I would advocate for PA catheter, aggressive Lasix infusion. If you're achieving your targets of return of organ function and you have safe hemodynamics, you continue to press. And if you can't meet your goal for output, then you ultrafiltrate. And that's sort of where I live my life.
So I agree with that. So there are a couple of things to say. If there is a target, a central venous pressure might be a useful target. So central venous pressure isn't all that useful. You'd really rather have RV pressures. But if all you got is, regardless of what you think about PA catheters, you almost certainly have a central line, and you can transduce that central line. And that might actually be helpful to you, because what you're going to find is your CVP is 12 and 13 and 14. It's not 3. It's not 0 like a motorcycle victim. It's 13, 14. And so if you have to target something, target CVP 8 to 10, say 6 to 7 to 8 to 10. And so that's number one of target. Secondly, you're not going to get there. It's still going to be 10, 4 liters in. So I diurese early and often. And the thing to say about diuretics is you will see people say they don't want to diurese people because of the risk of hypotension. The challenge is that hypotension in response to diuretics, particularly in this setting, is almost never hypovolemia. It is venodilation and vasodilation. So you give your diuretic, you need to diurese, and if your blood pressure goes down, you support the blood pressure like you do in everybody else with venodilation and vasodilation. You give a vasopressor, you support the blood pressure to where you need it, and then you diurese. So early, often, I go hard, I go early, I get big bolus doses, and I actually think a loop diuretic drip can be really useful in this setting. You start a drip, you get them going, you set them, you get them going 200 milliliters an hour, and the next thing you know, you've got 2 liters off and 4 liters off. And the last way, so how do we convince people to do it? I don't know. You bring them to a unit, you let them see Dr. Bartok, you let them see him do it and diurese somebody and make somebody better, and you let them see it do it again. And about the third time you convince and you say, maybe I should go home to my ICU and give that a try.
Those are good answers. Let me ask you, what is the most you've diuresed on one patient in any given day by volume?
15 liters.
Yeah,
15
I can
days.
think about. Yeah, I can think about, and think you probably remember one of our VV ECMO ARDS COVID patients who had such, had RV dysfunction intense anasarca. I think they got 9 kilos off in a 12-hour shift. Yeah.
Impressive.
Wow.
Yeah, and
All right,
we've run CVVH. We've run ultrafiltration at at 400 cc's an hour off. That's 5 liters. That's 10 liters if it goes all day. You don't usually do that, but even 300 is 7.2 liters, and that's fast. You're talking about people who are 30 and 40. That's generally heart failure more than ARDS. I should say that people with ARDS are usually not 12 liters up. And and even if they are, you don't need to get that 12 liters off all in one day. But a healthy diuresis is useful.
Fantastic. Thank you.
Great. So I'm going to ask one more question, if that's okay, Haney, and then we can go to the audience, unless there's more. So you mentioned the ECMO patient. So let's go to the extreme of ARDS. VV ECMO, ARDS, right heart fails. When are you thinking about changing mechanical support? Is there a role for right-sided unloading devices? Is there a role for VA? How does your mind wrap itself around that?
My mind is very, very weak. But we deal with this every day. I spent part of the afternoon supporting a patient just like this. I mean, I think, again, you sort of, the underpinning of this conversation is, have targets. So when you have a PA catheter and you can monitor the PAPI in a patient, on, just say you put somebody on VV with ARDS, sort of run of the mill, and then that RV starts to fail over time. We've had several that had to be converted to VAV, and then weaned off of, VAV back to VV. I think that it really depends on how the LV is working. And if that LV is just like these patients tend to be very distributive and hyperdynamic, it can be very difficult. And I think that more and more of us are looking to offload the RV, provide, oxygenation support without having to touch the arterial side. And I think that, the push is to, place a return cannula, through the PA. So I think that if you want to do full right-sided support, it's probably your go-to. Which is basically, VV ECMO VAD, because you're able to buy empty, offload the RV, and then provide oxygen support via the PA. When it comes to straight to VA ECMO, I think a lot of us think about the massive pulmonary embolism patient who needs acute organ support for definitive therapy, whether it's surgical thrombectomy or catheter-based therapy. I think there's a role for VA and then wean off of that, So that's our approach. I do think you have to have targets, just like for, with considerations for mechanical support for VA, we talk a lot about cardiac power output. I think for right-sided support, you have to, keep an eye on that PAPI, just like Dr. Hollenberg said, keep an eye on that pulse pressure. And as that sort of, you start to lose that, on top of everything, all the other modalities that you trend on a regular basis, I think you can start to think about whether or not that patient needs right heart support, and think about it early before they go into multi-organ system failure or become hypoxic because they're on VV and they just lost their right heart, so they can't do anything with that beautifully oxygenated blood you've been providing them. So, those are my thoughts.
Yeah, so I think there are 2 questions. The first question is up front, is when do you think you need VA ECMO? And I think, Jason, you're exactly right. You look at the clinical scenario and you look at the baseline left ventricular function. The second scenario is when it looked okay to begin with, and now the right ventricle is failing. And to me, that's exactly what you said. You're seeing either oxygenation failure or perfusion failure. So you're not achieving your goals with the VV ECMO, and then you say, well, if my problem is the RV and the RV isn't keeping up, then I need to put the blood. I need to support the arterial circulation as well.
Fantastic.
Yeah, no, the complex patient is the one who has, systolic cardiomyopathy and ARDS and then develops right heart failure. I don't know whether or not, putting a return cannula through the PA will then make their left heart failure worse. I think that's why you have to, again, have targets.
Well said.
Yeah.
Well, this has been a great discussion. I want to just kind of rapid fire go through some of the questions, and there are a lot of questions. So I'm going to pick two. I don't know, the two that I like the best. How do you like that? No offense to anyone else in the audience. These are all really good questions. I'm going to ask the question of, are we using this is from Randy. Anyone who knows Randy knows he's always on the show. Always saying good things. Are we using milrinone in ARDS enough when there is evidence of RV dysfunction?
Not when there's evidence.
Are we using milrinone when there's evidence of RV dysfunction? Are we not using it enough?
Again, RV dysfunction versus RV failure. When I think of RV dysfunction, that means the heart doesn't look right. When you think about failure, it means the heart doesn't pump. You mean that the RV, ejection fraction is down and there's no forward flow. So in RV failure, when you need inotropy and maybe some pulmonary vasodilation and offloading, I think milrinone makes sense. I'd love to hear Dr. Hollenberg's thoughts. Usually it's me grabbing something to make it work, milrinone.
Right. So I would say it exactly as you said. I would rephrase the question. I would say milrinone is not necessarily necessary for RV dysfunction, but it may be useful in RV failure. And my own approach is to start treating by RV failure by trying to modulate intravascular volume. But if I can't diurese somebody, or alternatively, if I'm diuresing somebody and I'm not fixing the problem, now it's time to ask whether an inotropic agent for the right ventricle, either milrinone or another inotropic agent. I don't know about you, there's a nationwide dobutamine shortage as of this week. So we're all going to have to learn how to use dopamine again. But an inotropic agent would be useful in that setting. We're doing it as of this week. I've got 4 people on dobutamine. That makes 4 in the past 5 years. Total.
Dopamine or dobutamine?
Oh, I'm sorry, dopamine. I've got 4 people on dopamine now. It's coming back.
You said learn. You said learn again. I never learned the first time, so.
Okay. I'm old enough to have survived the ages of renal dopamine when we were going to use dopamine to save the kidney.
I still live in those times.
Yeah, it depends what unit you work in. Some specialties still believe in it. So we'll leave it at that. All right, so let me just see if there's any other questions here, and then I'll let you guys go. I know you're super busy. Okay, so here's another question. Are there any particular vasopressors that work better than others with RV failure? I'll add in with any sort of pulmonary hypertension. There's always this works, has more PVR, this is more pulmonary neutral, not great studies. So what say you?
The classic answer is that vasopressin works a little bit better on the right side because it's more prominent on the right. Has more prominent vasoconstriction on the left without vasoconstricting the right quite as much. I think there's something to that, but I actually don't think it's like an enormous difference between vasopressin and others and the catecholamine vasopressors. So I think it's reasonable. But not so much that I always start vasopressin first. The norepinephrine is usually what you pull off the shelf first, and that's probably worth a try, and it's only if it's not working that you can either add vasopressin to norepinephrine, which is what you're commonly doing, and sometimes it makes sense to wean off the norepinephrine first and then leave the vasopressin in place. Jason, what are you doing?
I'd agree with that, and I think, your approach has to be specific for the patient. I can think about, a lot of us will use epinephrine or norepinephrine interchangeably. Vasopressin, I think, again, is also my go-to, when able. And again, I think it might be a better drug, if you have any arrhythmia issues. We know that patients with RV failure do not tolerate AFib very well. It's always something I'm concerned about if the patient's predisposed to AFib, trying to keep them out of AFib with RVR. I think a lot of us were taught growing up, again, like you said, dobutamine is on a national shortage. Got to use may have to use some dopamine. And we're all sort of taught that dopamine is a pulmonary vasoconstrictor at high doses and to stay away from it. I think that when you look at some of the data, it's probably not 100% true, but it might be my my last choice. If I have really high afterload, I probably wouldn't go straight to the use of dopamine, but I have a lot of other drugs in my arsenal.
I agree. And you know, actually, so to be fair, if you're going to, this is actually one situation in which you might conceivably use your scarce dobutamine in this setting for fear of vasoconstriction. If you don't, if you don't have milrinone, or if milrinone causes too much vasodilation, this might not be a bad place for using that scarce dobutamine. And there is some of it around, but we're conserving.
I'm going to start hoarding it all. I actually didn't know that. I'm going to start hiding it.
And the dobutamine stress tests are going to go away.
Oh, wow. I didn't even think about that.
Yeah. Interesting.
At least
gentlemen,
it's going to be several months. It's going to be, there's a shortage of raw materials. So it's going to be at least till the fall, till it's easy to get again. And maybe longer than that.
Adam, do you have any final thoughts?
No, that was great. Learned a ton. I really enjoyed it.
So let me just summarize the 3 things that I learned from tonight. I need to be doing more swans. I need to take at least 15 liters off all my patients, and dopamine is awesome, and I should be using more of it. I got it. All right, perfect.
You got it.
No.
Perfect.
Just no.
Perfect. You need a cardiologist now. Come to my unit.
No, in all seriousness, this has been phenomenal. You know, many of the things that we sort of hear kind of in the ethers of critical care with respect to the right heart, you've really solidified in strong physiologic concepts backed by data. And I'm, you know, while I don't like taking care of sick people from a like seeing anyone ill, I'm now excited to take care of someone with severe RV dysfunction and failure equipped with all this new knowledge. So I can't thank you enough for everything you've done for us tonight.
Well, thanks for having me.
Appreciate it.
Thank you.
All right. We'll get you on again sometime soon. Have a great night.
You too.
Adam, that was a lot of fun. 2 big brains on the program. That was, we almost didn't have enough bandwidth to support all that knowledge.
You know, they're my kind of guys. They kept it generic the whole time. Mm-hmm. I didn't think we were going to be able to get through that talk without one Impella, Protect Duo, you know, some sort of brand name. They really they kept it legit. I enjoyed it.
They did good. And left hook, I didn't see the dopamine coming. I did not see dopamine coming, but you know, that's how it goes. What was the most shocking thing that you learned from that, or the most eye-opening thing that you're going to take to your practice next?
You know, we didn't talk about it enough, but I think this concept of ventricular interdependence is just so incredibly important. You know, you talk about someone who's in cardiogenic shock from RV failure. That's the pathophysiology, right? The RV is preventing the LV. The high RV afterload is decreasing forward flow. And so the only way to fix that is to get over your hypervolemia, probably use some pulmonary vasodilators. And so you just, you know, diuresis will improve their shocks. And I think that's such an important thing to mention.
Yeah, I totally agree. It's one of those things when people aren't using echo very frequently and you show them and you explain to them the interdependence thing, you really can get them to start doing some of the things that isn't intuitive, like that aggressive diuresis. We got to get that septum over the other side, allow that LV to fill. And that's why they're having problems. They're not hypotensive because they're hypovolemic. They're hypervolemic, and that's what's holding them back. So that was just a phenomenal example that you just put out there. So another great critical care lounge under the belt, my man.
Yeah. I think, what is this, 12 or 13? I think it's 12 now.
We are getting up there in age. You don't look any older, though. You still look great.
Thank you. Appreciate it.
Should we tell them should we tell them what's coming up next on the next? Because we already know.
Yeah, I'm really, really excited about this next show. So we are going to talk about acute cholecystitis, specifically the critically ill patient with acute cholecystitis. And we are going to, I think this is the first time we're going to have 0 intensivists on. It's going to be a gastroenterologist, and an interventional radiologist. So I'm hoping we can talk about some of the different imaging modalities we use, how we treat it, how we think about it. I'm just really excited about it.
Yeah, that's going to be awesome. We're going to have to do some research because if there's no intensivist, I'm not going to know what to ask them. But we'll figure something out. All right, everyone.
We'll just, the default is just tell jokes, so we'll just do that all night.
We're good at that. We definitely are very, very good at that. Well, listen, it's always good to see you, Adam. And everyone, thank you for tuning in tonight. Don't forget to like and subscribe to the channel. We're going to be back in exactly 2 weeks. We're on a schedule now. We have optimized this machine that is the Critical Care Lounge, and we'll be coming to you very regularly every 2 weeks. So put it on your calendar. What's the date for the next one?
Oh, geez. I got to pull it up.
Oh, man, I put
2
you on
seconds.
the spot again. We didn't. We should have planned
I
this.
can't
I was
function
going to
like
ask
that.
you this question. What's 14
July,
plus 29?
July 6th.
July 6th
that make
is the
sense?
next one. Well, 2 weeks from now would be the 29th. No?
Yeah, so I guess it's 3 weeks. I guess everything we just said is a lie. But July 6th is the next one.
Right, great. Way to build our credibility for the show. We're already lying to you.
I blame you.
All right.
I blame you.
All right. Fair enough. All right, everyone.
All
Good
right.
to see you, and we will see you in some time.
Yeah.
All right. Take care, everyone.
See ya.